podcast and Around the Horn. Tonight we're going to be talking about underserved and emerging populations in athletic training. We're going to describe some emerging practice settings as determined by the NATA. We're going to give you a little bit of knowledge and skills necessary to practice in one of these emerging settings, and we're going to explore potential opportunities and threats to athletic trainers working in these emerging settings. So my name is Emma Nye, and I will be talking about athletic trainers in law enforcement, and I will let the rest of our DAT students introduce themselves, starting with Brittany.
Hi everyone, my name is Brittany Tadero. I'm a DAT student at Indiana State. I currently work with the ISU cross country and track and field team. And today I'll be talking about position extenders in the emerging setting.
My name is Chelsea Toney, and I'm also a current student in the Indiana State University Doctorate in Athletic Training program. I also work at Indiana State University with the cheer and dance team, and today I will be representing the dance setting for athletic trainers.
Everyone, Sean Rogers here, also a DAT student. I practice clinically with the men's basketball team at Indiana State University. I will be focusing on the tactical athlete of the structural firefighter today.
Hi, my name is Shannon. I am a doctorate in athletic training student at Indiana State, and today I will be representing athletic trainers in the outpatient rehabilitation setting.
Perfect. And if you could begin, Brittany, could you tell us a little bit about your practice setting job duties and maybe some opportunities and threats to athletic trainers working in your setting?
Yes, so with position extenders specifically, basically what the majority of them do is work in a sports medicine clinic overseen by most of the time a sports medicine surgeon. It could be a general sports medicine surgeon or specific to a body region. And from my experience and from what position extenders really do, I was an intern at University of Miami with a position extender under Carrie Riddle. And basically what I did and what she did was take patient history, blood pressure, all that stuff, patient history, would actually do a patient evaluation on the patient, and then after that, we would look over what we found, go report to the overseeing physician or orthopedic surgeon. He would take what our results are from the special tests and MMTs in the regular evaluation and look at it compared to the MRI or imaging that was taken. And then after we collaborated together and kind of discussed the differential diagnosis or helped physicians come up with a diagnosis, we all went into the patient's patient room together and discussed the issue with the patient and came up with potential treatment and potential rehabilitation, what the patient could do at that point. In my position extender setting when I interned, I was with Carrie Riddle, and what she did was she honestly helped out with injection of any sort of joint, so help with fluid drainage of the joint, injection of any sort of medication into the synovial fluid, synovial capsule. Will help with kind of invasive procedures like that through ultrasound or actual imaging ultrasound. So that would actually be a lot of. So based on that experience, I loved it. But there are some position extenders that are considered position extenders who work under an orthopedic surgeon or orthopedic district in general, and they're not able to do a lot of those things. Just from our experience, from some of the doctors that we know, I'm not sure if we exactly are able to do what I overseeing, looking at with the person I interned for. But there are specific residency programs available for extenders to gain as much knowledge as possible to be the best in the field that they can be. And a lot of them go over how to prep the area for patient injection, how to properly cast someone with plaster casting, and things like that. Now, in terms of threat to athletic trainers who are in this emerging setting, I think one of the downfalls of being in this emerging setting would be the scope of practice that we're allowed to do. And this will depend on or what the overseeing physician allows you to do. And of course, these residents will more than likely teach the highest level of what an athletic trainer is able to do in these physician extender settings, and that's basically probably the highest level that you can go, and is probably the best to accomplish to be a physician extender.
So do you feel like it's more of a collaborative approach between the athletic trainer and the physician?
So from my personal experience, yes. I'm definitely collaborative. From what I've seen here in Indiana, I think it's collaborative, but the athletic trainers are limited to what they can do. Just from my personal visual experience, all I've seen the majority of physician extenders do is take history questions and be in there with the general orthopedic surgeon or orthopedic physician while they're doing an evaluation themselves. And I think it may be different in every single place, every single setting, but again, that's dependent on what the physician will allow the athletic because they oversee that athletic trainer.
So how do you see us overcoming those challenges?
I think that in order for, physicians to, trust their abilities more and allow us to do more and they help the techniques and things like that, I think having all physician extenders required to go to the residency to get that higher education and learn exactly how to do each specific thing at an actual accredited institution will, I think, bypass those downfalls with the ability for us to do what we're going to do.
Does anybody else have any questions for Brittany before we move on? Chelsea, do you want to kind of elaborate on your practice setting?
Sure. So speaking specifically about dance in the performing arts setting, so say if an athletic trainer is working for a dance company, the major work duties involved here are offering, obviously, the athletic training services, prevention, diagnosis, treatment, and rehabilitation, as well as the emergency management skills and acute immediate care that we're all trained to do. But at this point, the athletic trainer is only required to be around for treatment before a rehearsal or performance. So some of the athletic trainers are employed through the hospitals, so they don't see a reason why athletic trainers need to be at a rehearsal or performance because nothing will happen. So if you're working as an athletic trainer for a dance company, there's a likely chance that you could also be helping out in a college, say with anatomy classes or anything in that regard. You may also have a clinical student working with you. After your day at school, then you go to the center where rehearsal takes place, and you get their dancers ready with any treatments that may be needed. The athletic trainer is not required to wait and stay for treatment following rehearsal or performance. So most performances don't start until like 7 or 8, and then post-treatment wouldn't take place until around 10 or 10:30 at night. So this is where the athletic trainers kind of consider how valuable their time is and their own work-life balance, obviously, and say, no, I can't provide you treatment at this time because they're obviously not getting paid for it either. So sometimes they'll say, you can go home on ice and I'll see you tomorrow. Now sometimes others will open the facility so the dancers can go in for an ice bath, but that's completely on their own terms. Others will take their personal kits and sit in the audience just in case something were to happen, and then offer their own personal time afterwards. This also goes for rehearsals if they feel like going to sit through a rehearsal or something. One big threat I see right now, and it's another reason why there are so few athletic training jobs for dancers right now, is that we're getting compared to physical therapists. Now I know this is just an issue throughout the whole profession, but it's significant in the dance setting. A lot of these companies already have a physical therapist that they utilize for treatment and rehab, but what they don't understand is what we as athletic trainers offer, which is those emergency management skills and the acute immediate care, which are the specific skills that can define us from physical therapists. So this is a reason why we do need to be present at rehearsals and performances, but they don't see the need for that right now. So I think that's definitely going to be challenging for athletic trainers in the dance setting to continue integrating ourselves as we need athletic trainers who are willing to fight that challenge and advocate for themselves and the entire profession, I think. We also need athletic trainers who are willing to take a huge step and develop athletic training positions at these places that don't have them, because there's a lot of dance facilities that don't even have an athletic trainer. And so these individuals should probably have good communication skills, especially if they want to be able to convince someone that they need this athletic training position in their facility. But I also see some people holding back because maybe they're not quite sure where to start or what's needed, who to go to, and so on. So I think they need the drive and passion to keep this going, to get more athletic trainers involved in the dance community. And I think I see a lot of our young professionals taking on these challenges, especially the ones who want to be leaders in our profession.
So would you say the biggest barrier to overcome is simply education?
I think that's a big part of it, especially educating our population in general.
What about, oh, go ahead, Brittany.
Sorry, Shannon. Chelsea, would you consider do you feel like there are a lot of professional dance groups out there that are able to utilize these athletic trainers? Would, for example, NFL cheerleaders be considered part of the dance culture, or would they be considered something else? I know the
so they have the cheer teams, and they have the dancers, who you see mostly, which you probably consider them to be cheerleaders. And I'm assuming they have athletic trainers, like the basketball dancers. They have athletic trainers, but these people are also involved, and the hospital is the ones who are paying them, and these are the ones who are also involved in the college settings, because they only have rehearsals at a set time and performances, because they can perform outside of basketball. So they're definitely utilizing them, but physical therapy is much larger in the dance population right now.
Does every major dance company have an athletic trainer? So, like, say, Juilliard or any of those big schools, like, do they have athletic trainers, like, at all?
There's a lot, especially in New York City, who don't have athletic trainers at all, mostly because they say, well, we have a physical therapist, why do we need someone at our rehearsals, why do we need someone at a performance? Nothing's going to happen. And the other interesting thing is, so I'm not going to say a lot of them because I don't know for sure, but some of these facilities don't even have AEDs, access to an AED. So that's something where the athletic trainers can also become involved and say, this is why I need to be here.
I think another barrier, if I might jump in, I had a close personal friend who actually was athletic training intern over the summer at Juilliard, and one of the big barriers that they also experienced was kind of the perception of what athletic trainers do to treat, because as we know, a lot of these individuals, both in dance and the performing arts, have a really important view on how they look, and not necessarily body image, but their actual entire image, all the way down to maybe the jewelry they're wearing or the outfit, because their whole goal of what they're trying to accomplish, unlike an athlete who's trying to make a touchdown or score a goal, is to kind of show an image. So sometimes these athletes and coaches similarly see, okay, we tape, we brace, we do some of these things, and then they're a little bit against that, and they don't want to take a step away from that. I think that's also really where we could focus on education, where, okay, hey, you might have some chronic ankle instability. You might think that all we're going to do for it is tape, but no, as athletic trainers, we can do X, Y, and Z to help treat this while still maintaining your personal goals as a patient. So I think that's one thing that we could also focus on with education.
Oh yeah, and unfortunately it's not just in the performing arts setting, it's in the whole athletic training profession in general.
Thanks, Chelsea. Shannon, did you want to talk about your emerging setting and how maybe it compares or differs from what we've talked about so far?
Yeah, so my setting is the outpatient setting. So in just a very light terms of outpatient is basically an athletic trainer working in a setting where the patient comes to you and then leaves. They usually have a set appointment. Usually this is like seen in a rehab clinic or in a rehab clinic within a hospital, or anything along those lines of a private practice, possibly as well. So with an outpatient clinic, the patient comes to you rather than an inpatient clinic where the patient is actually already within the hospital, where they just go from the hospital room to the PT clinic and then back to wherever they're staying within the hospital. So with an outpatient, your patients are usually able to get themselves to their appointment and not needing any further assistance. So opportunities with athletic trainers in this setting is that there is a growth of athletic trainers being employed into the outpatient setting. Athletic trainers are able to create rehabilitation plans, are able to do an eval, they're able to have hands-on and do reevaluations. There's a lot of times where people forget that we can do the evaluations, and a lot of people think that we just, give an exercise, throw some tape on them, and say you're good. But because of the opportunities given at an outpatient clinic, people are starting to see that athletic trainers do more than just tape ankles. So that is an exciting thing that athletic training is growing in that setting. Still has a lot more to grow. The threats with this, though, at the same time, is that athletic trainers are likely to get confused with PTs, with physical therapists. So people will see that if a physical therapist creates a rehab and gives them home exercises to do, and I'll see you in a week, and people see the same thing of PTs will do exercises, give them a home exercise, and see you in a week. So I think making sure that people know the difference between a physical therapist and an athletic trainer, making sure that we educate our patients of what we do, how we have a preventative part to our profession, as well as screening and emergency settings as well. I think another important part with outpatient is to let people know that athletic trainer does not mean that we only work with athletes. A lot of the time in outpatient settings, the patient are industrial, working in a more traditional setting of an office sitting, or maybe industrial working of moving boxes around, or mass productions. So letting people know that we don't only work with athletes, D1 high school athletes, or NCAA, that letting people know that we work with another population as well, of the working class. So I think making sure that we educate people about that, that we don't work with just athletes, educating that we are not PTs, but we can also do similar things as PTs, and we can still work in the same setting and work side by side with PTs, but we are not the exact same. We have different credentials, we have different degrees. And then also, we have our opportunities of growing as athletic trainers in the outpatient setting.
Great. Does anybody have any questions or thoughts on the outpatient setting?
So there's new things out. So they just changed the name from a physical extender to athletic trainer working in the physical therapy setting. Isn't that the name of it now?
I believe so. They wanted to make sure that there's no confusion with anything, because depending on what state you're at, and all those legal actions of billing. So billing is huge depending on what state you're in. Athletic trainers can bill, but a physician extender, or depending on what state, a physician extender can bill, but a athletic trainer, depending on what state, cannot. So they wanted to make sure that the title is very clear, that making sure that when you bill, you're using your title of athletic trainer. There are two codes specifically for athletic trainers, for evaluation and reevaluation, and then but those two are specifically just used by athletic trainers.
So you're saying that the title of the person is important, meaning that if you're billing and you're an athletic trainer working as a physician extender, you have to put for insurance if you're billing as physician extender, not athletic trainer, or something like that. Okay,
Yeah.
interesting.
You can't bill as a PT. Someone else can't bill as a physician if they're not a physician. So like you have to make sure that you're using your job title for the code that you use.
Do you feel that having an athletic trainer work in the outpatient setting is compared a lot of times to physical therapy assistants?
Yes. So there's a whole bunch of different titles in physical therapy. So you have your physical therapist, you have your physical therapist assistant, and then you also have a physical therapist aide. So an aide is not able to really prescribe any physical rehabilitation exercises, but a athletic trainer can. A DPT can prescribe a exercise, and a aide cannot. An assistant can, but they have, I would have to double check, but they have to have clearance. They can create a rehab program, but it has to reach clearance. And then the aide, they just facilitate. They do not create any rehab. They just facilitate and instruct the patient on the prescribed rehab from the DPT.
And do you think would the physical therapist be that overseeing the athletic trainer? So would the athletic trainer have to report back to the physical therapist with every single decision they want to make, just like the physical therapy assistant would?
So that's a not difficult, but there's two answers to this: yes and no. So the overall answer if you check on NATA and just in athletic training in general, no. The athletic trainer is not overseen by the physical therapist. The athletic trainer works in communicates with the physician. So just how in an athletic training, like at a college setting, how you work underneath the physician, it'd be in the same setting. But depending on what clinic you work in, on how the system they are in, and also if it's a private practice or not, depending on the clinic, you possibly could be underneath the PT, but in the overall setting, no, the athletic trainer does not work underneath the PT.
So then, would you say that it would be detrimental for an athletic trainer to take a position as a physical therapist aide or physical therapist assistant, rather they should only agree to work in outpatient settings where there's a physical therapist, maybe in a practice setting if they're employed as an athletic trainer? Would you say that's accurate?
Yeah, I don't think if you're an athletic trainer, you should not be applying for jobs as a physical therapist aide. You are hurting your own degree, and you're hurting other opportunities for people who, could have that position instead. I think as an athletic trainer, you have the opportunity to work as an athletic trainer. You have the opportunity, if you work as an aide, I feel like you are actually lowering yourself. We as athletic trainers, we are taught how to create a rehabilitation program for various injuries. A PT aide cannot create a rehab program. So I feel like if you go to an outpatient clinic and you end up having the title of an aide rather than an athletic trainer, then you're actually being detrimental to your own degree.
Yeah, the aide basically they help put heat packs and electrical stimulation pads on. They help set up stuff. The assistant will work under the physical therapist, but they have to get approval from the physical therapist before they do anything. And then the athletic trainer is kind of autonomous in a way.
Yeah. So I've actually did some volunteer hours back when I was in high school. At a PT clinic, and there was 2 athletic trainers that were also there, and they were able to, it kind of did seem like they were autonomous, and that they didn't have to seek approval by anyone for the rehabs that they were prescribing to their patients. But I think the hardest thing was that people didn't know that there were some people that thought that those two athletic trainers were physical therapists. They didn't know the difference between the two. They're like, oh, well, I'm going to see, John, and then I like, if he's not available, can I see Sue? Well, Sue's an athletic trainer and John's a PT. Like, those are two, like, there's a lot of patients that didn't know that, like, there's a difference between the two. So I think making sure that we educate patients that, hey, there is a difference between the two.
I agree, and I think if an athletic trainer takes a physical therapist aide job and then decides that maybe they want a different job in a PT clinic working as an athletic trainer, or a high school, or a college, or an industry, they've missed the critical thinking skills that is required to be an athletic trainer. I mean, it's detrimental to their growth as an athletic trainer. Sean, do you want to give us some insight about the work with firefighters?
Absolutely. So the underserved setting that I'm going to talk about today is the public safety sector, specifically firefighters. I think, Emma, you're going to talk a little bit about the other side of public safety. So earlier I mentioned a tactical athlete. I wanted to explain that a little bit more. The definition of a tactical athlete is a little bit aloof, but essentially it focuses on an individual who in their occupational setting has to perform at a high physical level. So in this case, we could talk about maybe the military, where they have to go through boot camp and they have to maintain that level of physical fitness to stay within the military. Or specifically in my case, we could talk about firefighters whose job is inherently physical, especially when you're fighting structural or kind of wildland fires. So with firefighters, this is an amazing setting that athletic trainers can really flourish in. I looked up some statistics from the National Fire Protection Agency, and in 2014 there was about 63,000 injuries that were reported by firefighters alone within the United States, 60% of which were musculoskeletal, and about 20% of which were non-emergency general medical. So this presents a great opportunity for athletic trainers to treat some of these injuries, but I want to go a little bit further down, a little bit away from that surface level. So this huge amount of injuries that we see are actually usually the cause of the firefighter, whether it be a structural firefighter fighting building firefighters or a wildland firefighter doing some of those like forest fires. Most of the injuries are seen on the job, whether that's running into a building, whether that's a burn from the fire, whether that's, falling in a crevice when you're fighting a forest fire. These injuries are seen within the workplace. Now, when we think of injuries, we usually, just because of the way that our education is based, we think of an athlete running down a field and getting hit, or an athlete running down a field and twisting their, leg, falling down, they get hurt. These individuals are wearing 30, 40, maybe 50 or 60 pounds of gear, which is going to inhibit their physical performance, which predisposes them to injury. And it's actually some of the research that I'm doing right now in association with Dr. Kenneth Games at ISU, is how we can look at this population and we can assess their kinematics, especially within the lower extremity, and maybe even create a screening tool, or at least identify a problem connecting the sort of gear that they wear to this specific risk that they have for injury. So not only are athletic trainers, would they be available to treat injuries and offer general medical consultations, they could also really help in kind of the assessment of kinematics for individuals. Similar to PPE for athletes that we're so accustomed to, screening for some of these firefighters before maybe they start their employment, or before they go out in the field and fight some of these fires. Now, talking a little bit about some of the challenges associated with this. One of the first challenges is it's very new. There are not a lot of athletic trainers that work within the public safety sector. So while it's still kind of in its birthing years, there is a lot of money available. Now, I was doing some research to try and find the number of athletic trainers who currently work within the public safety realm with firefighters specifically, and from what I could find, there's not that many. Actually, some locally down in Missouri and St. Louis, it was one of the first fire districts to actually employ an athletic trainer, so I did a little bit more digging, and this athletic trainer actually works for the district. And they hold sort of clinic hours where the firefighters can come into the physical therapy clinic where the athletic trainer is employed, and the athletic trainer can evaluate, treat, and prescribe rehabilitation as needed. So I think that's a really good first step. Now, while it might not be feasible to get an athletic trainer in every single firehouse throughout the country just due to sizes, if we start in some of the bigger cities and some of those metropolitan areas where an athletic trainer maybe bounces between 2 fire districts, offering their skills in assessment, screening, diagnosis, and rehabilitation, I think that's a really good opportunity. And if we also focus on pushing the profession forward and how this is important, when we look at athletic trainers, what a lot of people see us as is specifically sports medicine. We specifically work in the realm of athletics. Now, if we look at the kind of money involved, and while it might be kind of inconvenient to look at, money is essentially what makes the world go round and what helps us push ourselves forward. In the world of athletics, we save a lot of money with our skill set and how we work. But if we go into the occupational setting, you look at L&I claims, and that eclipses any sort of athletic injury spending wholly. There is billions and billions and billions of dollars available within that kind of workman comp L&I area. So if athletic trainers can put themselves out there and show that in a population with a tactical athlete that they are saving money for not only the fire district but for these insurance companies and the government because of their skills rendered, this is really going to help the athletic trainers expand themselves into this field and as well as expand into other emerging settings as a whole.
Does anybody have any thoughts or questions for Sean?
Do you know how many athletic trainers are currently employed with fire stations? I don't know. Do they get employed with fire stations, or how does that work? How does
usually what happens is that, and I haven't found an example of an athletic trainer that was directly employed with a fire station or with a fire district. I actually only found 2 examples. I did I wouldn't say an exhaustive search, but a pretty decent search. And the 2 athletic trainers were actually working at a physical therapy clinic which contracted out to the fire district. So similar to kind of the model that a lot of places use to provide coverage to local high schools is the model that we saw. Now, I do think that there are some problems with that model, and me personally, I don't believe that an athletic trainer should be working in a physical therapy clinic which owns the contract, because I feel like there's some areas of just differences of, what's the word I'm looking for, like a difference of opinion or some other biases that might be involved there. I think it would be a lot better if athletic trainers could move into employment with the fire district directly, because that's just one last level that they have to go through working in their employment. To answer the second part of your question about how many firefighter athletic trainers work in that area, I looked on the NATA with some of their members' records, and I only found the 2 that I was talking about. So I'm assuming that there are more out there, and maybe that they just don't put themselves out there. They haven't registered with the NATA, but I was only able to find 2, one in Arkansas and one in Missouri.
So, Sean, do you think telemedicine could play a huge factor with athletic trainers and firefighters? Do you think that could be one way?
Absolutely, and I think telemedicine would be an excellent tool to use with this population, because when we think about firefighters don't have a typical 8 to 5 job, a 9 to 6 job. Firefighters are on call 24/7, so much so that in firehouses there's usually a resident staff which rotates weekly, where 5, 6, 7 people, depending on the size of the district, are going to stay there 24/7 in case there is a call. So if you think about telemedicine, it's a really convenient way that an athletic trainer or healthcare provider could access this population and could sort of break that barrier of a time and location. So maybe a firefighter at 10 o'clock at night on the East Coast wants to have an evaluation, and an athletic trainer on the West Coast where at 7 p.m. is available to do that over telemedicine. Great. Or maybe when this firefighter is off duty, they've just completed their 7-day rotation of 24/7 coverage, maybe that's when they want to do that. They don't want to have to go into that firehouse because they've just worked 7 days a week. They could access that service from home. So I think, yes, telemedicine would be a great way to access this population.
Okay, so how do you think billing would work that way then? So if they're working with different athletic trainers who are available for them, right? Is that what you were just saying?
Yes.
Like
I think that the first barrier, and the very first barrier that we have to approach, is getting athletic trainers recognized by major insurance companies, Medicare, Medicaid, other private insurance companies. Because as it stands right now, there are only a few states in which athletic trainers can use those codes that Shannon was talking about for evaluation, reevaluation, and treatment. So that's where it gets a little bit tricky, and that's why athletic trainers, at least this is why I think athletic trainers are currently operating under the Work for a Physical Therapy office that has a contract with the fire department, because if an athletic trainer provides a service that there is not a code for, that that Medicare and Medicaid will not reimburse for, a physical therapist can use that code to get the money from the insurance company. So I think that's the first step. When it comes to the logistics of whether you could have an athletic trainer do the evaluation and through telemedicine and a different athletic trainer treat, I think that's going to be purely logistics, whether or not someone sets up a company that's purely telemedicine and then they have a local outreach clinic, physical therapy or otherwise. So I think that would be logistic based on a private company that chose to start that up.
I think a lot of the barriers you talk about and opportunities are really similar to my setting in the law enforcement. Basically, the job duties of an athletic trainer working in law enforcement are, reducing workers' compensation costs from these injuries that are not athletic injuries. We're not talking about, like you said, running down a field and twisting their knee. So athletic trainers in law enforcement, not only they do clinical assessments and actual patient and medical care, but they do things like nutrition and stress reduction and maintaining appropriate blood pressure and concussion education and management, because these are things that this population of patients aren't getting. And if they are getting them, it's in a very informal training seminar or getting them just from their primary care physician. So a lot of times the athletic trainer in this setting is doing collaboration with like risk management and human resources, talking about injury trends in this population and management of long-term employee injury resources. So it's really, really non-traditional, which I think is really interesting and corresponds to a lot of what you were saying, Sean. In terms of different job duties of an athletic trainer in this setting, the athletic trainer really collaborates with the department safety officers, like personnel dealing with heat illness prevention, physical safety issues, infectious disease transmission. We're talking about police officers that are involved with violent, potentially harmful people, and the athletic trainer kind of have to shift their mindset to deal with this type of injury or pathology. But if we talk about opportunities for future growth, I actually found statistics that athletic trainers can actually reduce overall medical costs in this population by 49.5%, and wow, musculoskeletal medical costs by 86.3%. So I think if we're going through medical cost alone in terms of opportunities for future growth, that statistic was pretty astounding for me. And then when we're talking about concussions, some of these officers obviously assume kind of a tough warrior-like attitude when they're injured, and therefore may be unlikely to report a brain injury. So this is another opportunity where athletic trainers can come in and educate. I think maybe a threat to future growth or some challenges in this setting is that funding for an injury care and prevention program may come from grants from local hospitals, physicians, or donations that probably law enforcement agencies in rural areas may not have. But I think overall the skills needed for this population is really collaboration, specifically when I was talking about risk management and human resources. injury prevention, so they don't have to do as many clinical assessments, the nutrition, and the concussion education.
Emma, I think you brought up a bit.
I really like.
Oh, sorry. Go ahead, Shanna.
Oh, I was just gonna say I really like that you brought up the concussion awareness, because we don't really think about how in law enforcement that really is a not super common injury, but it is something that in their line of work is more possible. So I thought that was very interesting, and definitely something that we want to make sure that we are taking care of our law enforcement.
Absolutely. Well, does anybody have any other questions or thoughts for any of the Around the Horn members?
One last thought. I think just overall having athletic trainers in these settings just increases efficiency, because in some of the studies shown with the physician extenders, that can probably relate to all emerging settings, that we increase patient throughput, or the amount of patients per day, with an orthopedic surgeon more than a physician assistant or nurse practitioner would. And we have more of that musculoskeletal specific knowledge than they do. So I think we are there to increase efficiency and just do the best job that we can do, better than a lot of other healthcare professionals may be able to do.
I think the big theme of this whole thing is education and advocacy. I think we all mentioned it with each of our populations, so I think that's huge.
Absolutely. All right, well, thank you all for listening, and this was our Emerging Settings Around the Horn podcast.